Good afternoon. Welcome to the symposium on childhood allergies. So we have three eminent speakers today to talk on three important topics: drug allergy, food allergy, and a practical approach to desensitization. So first of all, I would like to invite Dr. Duminda Samarasinghe to welcome you all to this symposium.
Good morning, good afternoon, ladies and gentlemen. On behalf of the Sri Lanka College of Pediatricians, I would like to welcome you all to this symposium on drug allergy. And there are three eminent speakers, and first lecture will be done by Dr. Dhanushka Dassanayake, and next we have Professor P K Vedanthan. I heard both of them are experts in allergy. I'm also an expert in food allergy because I have certain food allergies. So I have become an expert now. So I think it's an interesting and very important topic. I hope you will gather the maximum out of it and use it in your day-to-day practice. Thank you very much for coming all the way to speak to us on these important topics. Thank you.
So we will start with the first presentation on drug allergies in children, what you need to know. So it will be delivered by Dr. Dhanushka Dassanayake. She's a consultant immunologist at Medical Research Institute. So after the three lectures, if we have time, if time permits, we will have a panel discussion to discuss your questions. We will see, because we have already received some questions from y'all, we'll try to answer all these questions.
Good afternoon, and thank you very much for the opportunity. So my topic is drug allergies in children. So I'll try to cover as much as possible within this 20 minutes. So let's see how long I go up to. My case today is a very simple case. It's of a 12-year-old girl from nearby who is a known wheezer. She had something like an upper respiratory tract infection, and on third day, because she had fever, she has gone to the private practitioner and was given chlorpheniramine, salbutamol, and amoxicillin. So she has taken the first dose at 9 p.m. and around 10 she has developed itchy rash on the limbs. So what happened on day 2 was when she woke up, there was only mild itching, but around 6:30 she was given the second dose of amoxicillin and paracetamol. In about half an hour she developed generalized urticaria. Along with it she got angioedema as well. She didn't have features of anaphylaxis, but the parents rushed her to the ETU LRH. So there she was treated and discharged, and there was a small query of beta-lactam allergy, and the parents were quite anxious. So because they were referred to us, they came to our institute the following day. So when she came, we did the initial assessment. So in drug allergy, the main component in assessment is the history. So all these information we need to assess the allergy. So if any of you all are referring patients, you need to see that this information is there, because otherwise you can't have a meaningful assessment. So these are the questions and the answers on the other side. So basically she is a child who had a cutaneous manifestation of a reaction following ingestion of amoxicillin and paracetamol. So I have taken the salbutamol out of the equation because she was not given salbutamol the following day, and she didn't have anaphylaxis. She was treated, and she has taken both amoxicillin and paracetamol previously without any incidents. So when a child like this comes to us, what is the differential diagnosis? Now, especially in her case, so this could be due to an infection, or it could have been due to paracetamol allergy or beta-lactam allergy, or it might have been due to COX inhibitor intolerance. So those are the differential diagnoses I will be dealing with. So infections and urticaria. So actually, viral infections are the commonest cause of acute urticaria in children. So this happens sometimes due to the infection itself, so the organism causing problems, or due to the interaction between the organism and the medication. So classic example is EBV and amoxicillin. So about 30 to 100%. So sometimes all patients maybe who are given amoxicillin or ampicillin during a EBV infection might end up with a morbilliform rash. So there are specific viruses associated with this kind of urticaria. Herpes viruses are the commonest lot, and even with diarrhea caused by rotavirus or norovirus maybe, you can still get urticaria. And certain viruses are associated with even more severe reactions, such as severe cutaneous reactions. So why would anyone get urticaria in acute infections? So the immune complexes that form the organism plus the antibodies, they can activate complement pathway, or they can stimulate basophils to produce vasoactive amines. So especially in patients with viral hepatitis, there can be hyperbilirubinemia, and that itself could lead to vascular permeability. And in certain infections, there are certain proteins that are secreted, especially in the intestinal tract, which might lead to the release of various pro-inflammatory mediators. So these pro-inflammatory mediators, increased vascular permeability, and increased production or release of vasoactive amines will lead to urticaria in viral infections. So then we'll talk about adverse drug reactions, because our next differential diagnosis are of adverse drug reactions. So what I want to highlight here is that adverse drug reactions are unintended reactions that occur with doses that are normally or usually given to patients during treatment or prophylaxis. So it is broadly divided into two main sections, type A and type B. So type A is also called on-target effects. They are predictable and dose dependent and are responsible for the majority of reactions that you see. Overdose and side effects are examples. Whereas type B reactions are off-target effects. Those are unpredictable and dose independent. So drug hypersensitivity falls into off-target reactions. So in drug hypersensitivity, apart from the allergies you see, intolerances, idiosyncratic reactions all fall under this type B reactions. So what happens when you take a drug? How do they become antigens? So if the drug is big enough, it can be like an antigen and cause the normal reaction. So for example, antiserum and recombinant proteins, all of these by itself can be antigens. But sometimes you need it to be bound to another multivalent chemical that is able to stimulate the immune system. For example, neuromuscular blocking agents, you have ammonium compounds, and in steroids and other drugs, of course, you get carboxymethyl cellulose. So all these things can activate the immune system and lead to a type 1 reaction. So most drugs are quite small, less than 1000 daltons, and unable to cause reactions by itself. So therefore, it has to be conjugated to another carrier protein. So this process is called hapten protein complex formation, and some drugs such as beta-lactams are able to directly form bonds with carrier proteins, but some drugs, they need to be turned into metabolites, and these metabolites only act as haptens. So via haptens, you can get type 1 to type 4 reactions. So this is another recent something that is quite interesting. Here there is pharmacologic interactions with the immune receptors. Now instead of binding to the antigen present in cell or the T cell receptor like in the normal immune response, here the drug can go and bind a temporary bond with either the HLA or the T cell receptor. So this is transient. And what happens is ultimately this bond would be enough to stimulate the T cells. So the T cells can lead to even serious reactions such as Stevens-Johnson syndrome, toxic epidermal necrolysis, but this is only a transient bond, so it is not like what you see with hapten complex formation. So what are the non-immune mediated reactions? So some of the clinical features resemble immunological reactions, and when they come to the hospital, it is very difficult to differentiate based on the clinical features. So with non-steroidal anti-inflammatory drugs, it will prevent arachidonic acid conversion to prostaglandins and thromboxane. So the accumulated arachidonic acid will convert into leukotrienes, causing problems. And certain drugs such as opioids by itself can directly stimulate mast cells and lead to reactions. Now this concept of MRGPRX2 again is kind of recent. So in the normal reaction, the allergen binds to the IgE, so the stimulation is through the IgE pathway. Here the drug can interact with the MRGPRX2 receptor and cause release of mediators. Now, unlike the immune-mediated reaction, this reaction is dose and rate dependent. So, classic example is red person syndrome with vancomycin, where like if you reduce the rate, you will be able to get away with giving the infusion. So, we can divide drug allergies based on the onset as well. So, reactions that occur within the first hour are called immediate reactions. So, your type 1 hypersensitivity usually falls into that. But sometimes even with type 1 hypersensitivity, say you ingest the drug along with some food and there is delay in absorption, you might get symptoms even after 1 hour. So, this boundary has been stretched up to 6 hours now. And type 2 and 3 hypersensitivity reactions generally occur within hours to days, and type 4 hypersensitivity reactions generally occur days to weeks after the exposure. So, this is the mechanism. In antibody-mediated drug reactions, it might be IgE antibodies leading to type 1 hypersensitivity. Now, that is the classic example of urticaria, angioedema and anaphylaxis occurring after drugs. And then you might also get type 2, that is IgG mediated or immune complex mediated reactions, giving rise to various other problems. So, T cells also could give rise to drug hypersensitivity. So, depending on which pathway is stimulated, you might end up with different symptoms. So, say if it's a Th2 response, then you might end up with something like drug reaction with eosinophilia and systemic symptoms, or the DRUS, where the main mediator is eosinophils. So, if cytotoxic T cells are stimulated, here there can be keratinocyte deaths. So, this is what happens in Stevens-Johnson syndrome and toxic epidermal necrolysis. And also in acute generalized exanthematous pustulosis, due to the stimulation of neutrophils, you might end up with these reactions. So, you get different rashes due to drug allergy. So, this is the classic example, hives and angioedema. So, angioedema is due to the mast cells in the epidermis and the subcutaneous tissue. So, it is mostly skin colored and takes longer to subside. Also, it is more painful rather than itchy. So, these are some other rashes that you would see with a patient with drug allergy. So, morbilliform literally means measles-like. So, you might see something like this after infections or with EBV and amoxicillin interactions, or maybe you might see this in a more angrier background in DRUS syndrome. So, in AGEP, you see sterile pustules and there is, these are non-follicular. So, in fixed drug eruptions, each time you ingest the drug, the reaction, something like this rash, will occur at the same place. So, the postulation is that it is due to memory T cells that are trapped in certain areas of the skin, which get stimulated with subsequent exposure. So, the last two pictures are of 10 and Stevens-Johnson syndrome, where if you have more than 30% of the body surface affected, it is 10. If it's less than 10, it is SJS. If it's between 10 to 30, it is overlap. So very briefly, what happens with PCM? So PCM can cause urticaria by two different mechanisms. One is COX inhibition and the other one is selective allergy. So allergy would be Ig mediated. It is quite rare, and here the patient can tolerate other NSAIDs without a problem. So skin prick test is not really useful in detecting PCM allergy. So only about 11% will have a positive result, and only way to prove would be oral provocation challenge. So majority of the reactions you see are due to COX inhibition, like what I mentioned for NSAIDs. So these are weak COX inhibitors, and generally they are unable to tolerate other NSAIDs. But out of the patients who are unable to tolerate NSAIDs, about 97% will be able to tolerate paracetamol. So beta-lactam allergy, this is the drug, other drug that I am focusing on. So beta-lactams are drugs that have this beta-lactam ring in the middle. So based on the structure, it can be divided into 4. Monobactams have only the beta-lactam structure. The cephalosporin, instead of the thiazolidone ring you see in penicillins, you would see a dihydrothiazine ring, and carbapenems in the thiazolidone ring, the sulfur bond is replaced by a carbon double bond in one place. So this is the most prevalent cause of drug hypersensitivity reaction in children, and the estimated prevalence based on the study is 1 to 10%, but the actual confirmed allergy is much less. It's only about 2%. So beta-lactams can cause type 1 to 4 hypersensitivity, and usually they act as haptens, but some other drugs such as flucloxacillin can act as haptens as well as lead to pharmacologic and immune receptor interactions. So there is cross-reactivity among beta-lactams, and this type of diagrams you can get all over the internet. But the main thing here you have to understand is the risk due to the shared beta-lactam ring of a cross-reactivity is quite limited. I mean, it's mainly theoretical, but still if there is a severe reaction without doing a test, you will not prescribe the drug. If you have identical side chain, which is the other cause of hypersensitivity, then you can't prescribe those drugs that have the identical side chains. So some side chains might be similar, not identical. There again, you might have problems. So some of these have been proven to cause cross-reactivity. Some of these are just theoretical, but you have to be familiar when you prescribe which drug to select out of the lot if you really have to give another beta-lactam in a person who has previously had a reaction to beta-lactams. So going back to my case, now the patient came the next day after the reaction. So what we said was to basically avoid beta-lactams, paracetamol and NSAIDs. And we also advised on emergency care in case that reaction was not due to the drug and was something else. And we asked her to come back in a few weeks. Ideally, you have to wait 6 weeks following anaphylaxis to do a skin test. But here, even though she just had urticaria because there was no urgency, she is not a person who needs antibiotics quite often, we asked her to come back after some time. So when she turned up, she didn't have further episodes, and we carried out a SPT for beta-lactams at the LRH ETU. So generally, this is the testing plan for beta-lactam type 1 hypersensitivity. You select the patients based on the history, and you get them to go through a skin test. And if the cutaneous test is negative, you might go for an intradermal test. If both are negative, you might go for a drug provocation test. And if all of these is negative, you delabel that patient. If one is positive, then you label the person as having an allergy and then give advice accordingly. So some guidelines say in children, the risk of beta-lactam allergy is quite low. So if the symptoms are just cutaneous and it's few years back and there was no features of Ig immediate reaction, just to go for the oral challenge rather than going through the testing. And in some studies, they have just gone for intradermal test without starting from skin test. And in certain studies, they have just done skin test. And from there, if it's negative, without doing the intradermal, because it's painful, they have gone to the drug provocation test. So what we did for our patient was the beta-lactam skin test. So when you do a skin test, you are supposed to have a positive control and a negative control. So the positive control is histamine and the negative control is normal saline. So ideally you are supposed to do it with the major prepen and minor component penicillin G. And in addition to that, if the reaction is due to amoxicillin, you have to test amoxicillin. If the reaction is due to co-amoxiclav, you have to test the amoxiclav, both components as well. So if the skin test is negative, you have to go for the intradermal test. So in Sri Lanka, we don't have these major and minor determinants. So therefore, we have to make do with the in-house preparation of the drugs. So this is data from a study done in Australia. So they have done a cost analysis. So they have shown for this particular 127 patients where they tested with the drug itself rather than the major and minor determinant, they have managed to make a huge saving. And also they have shown that the negative predictive value of in-house kits is about close to 90%. So it is, I think, good enough for countries where amoxicillin use is the predominant thing that is there. So if it's penicillin, the case might be different, but even for our country, most of the cases are coming with query amoxicillin allergy. So going back to the case, now since the SPT was negative in this child, we went ahead and did the oral challenge on the same day because she didn't have, she only had cutaneous problems and we thought that is due to a viral infections. So we decided to go for this because the parents are quite anxious. So so there was a query of paracetamol allergy as well. So sometime later, we asked them to do an oral challenge for paracetamol as well. So she didn't have any reactions to either, and she was successfully delabeled as not having a drug allergy. Because of the time constraint, I stopped there. So if you have any questions, probably we can answer some during the discussion. Okay, thank you very much.
Thank you, Dhanushka, for that very insightful lecture. So for the next lecture, I would like to invite Professor P K Vedanthan. He's the Clinical Professor of Medicine, Department of Medicine, Division of Allergy and Asthma, University of Colorado, USA. And he's the visiting professor at the Department of Pulmonary Medicine, Christian Medical College, Vellore, India. And he's the co-director of many training programs, postgraduate training programs in allergy and asthma, including the one at CMC Vellore. Over to you, Professor Vedanthan, to talk on food allergies.
Thank you very much. Ayubowan. It is a pleasure for me and my wife Kamala to be back in your beautiful island of Sri Lanka. Actually, I mean it. We are having a wonderful time along with our alumni. We are about 40 of us traveling through Sri Lanka in the last 4 days, and we are here for another 3 days. And we are enjoying our trip. And I am in the vacation mood, so do not ask me very difficult questions because my thinking is very slow because I am in the vacation mode. But even during the vacation mode, I had the pleasure of contacting Gawin, Dr. Ineage. Sorry about that. Govani. I call her Govani more, Lineage. And Dr. Ajit Amarasinghe. These are two alumni of our training program at Christian Medical College, Vellore. I am very happy to also say Dr. Govani was a gold medalist at our program. And Dr. Arjit Amar Singh gave me a fantastic tour of Sri Lanka, north, south, east, west, about 6-7 years ago. So I have a lot of pleasant memories. I know you are tight on the timing, so I'm trying to stick to the timing. And the topic that we are going to address today is a very hot topic, especially for pediatricians. Even surgeons are interested in this topic, like food allergy. Food allergy is a topic that is evolving rapidly, changing significantly, and what we used to say about 10 years ago, we are reversing 180 degrees and telling opposite, because we have a lot of evidence now in food allergy to say certain things very confidently also. At the same time, I have to say a lot of data that we have right now is Western data. And Western population, epigenetic changes in Asia compared to America, as well as our habits, our cultural backgrounds, our microbiota is different. East and West are different. So it's very, very important for us to start collecting Eastern data. So that is why we are interested in Sri Lanka. We are interested, whole world is interested in India, I would say Indian subcontinent, which includes Sri Lanka. Why are they interested in this part of the world is the question. You see that we know that allergy is a classic disease of gene-environmental interaction. You can't change the gene, but environment is very different between East and West. And what we have found is the environment in our part of the country is very hostile for allergies. But in spite of it, if you look at the prevalence of allergy in India, especially food allergy, is less than 1%, 0.11, 0.15 like that. Whereas the prevalence of food allergy in the West, like Western countries, including Australia, UK, USA, is 10%, 100 times more. You don't need a statistician to say it is highly significant. So there is something in our environment, the way we live, the way we eat, which is sort of protecting us. That is why the whole allergy community across the globe is interested in our part of the world. So that is just for introduction to say that there's a lot of data that we need here that will benefit rest of the world. That is the whole point. So they want to know, how is it you people are eating peanuts all over every day you eat peanuts, but the prevalence of peanut allergy is extremely low in your country. How is it you are eating so many different antigens and your sensitivity to overall is so low? So that is why the whole world is interested in us. I just want to convey the message that you please take the topic of food allergy more seriously and start collecting data. That's very important. Now, I presumed, and I did tell to Dr. Govani that I am not going to go straight jump into food allergy. I want to cover some basics because I don't want to presume that people know all about the mechanism of allergy. I know there are several immunologists here and there are very highly knowledgeable pediatricians here, but I'm presuming that some of you may not know what is allergy. I'm presuming. So I'm going to talk about some basics before I go to the specific topic. So what is allergy? Allergy is nothing but an exaggerated reaction. It's an immunological reaction. It is against harmless substances. Nobody is worried about dust, mite. Nobody worried about pollens, cockroach, cat, dog. We don't even look at them. But people who are allergic are highly aware of it. Highly aware. So they get exposed to it, they get a significant reaction. It's an immunological reaction. And if you look at the immunological reaction, allergic reaction actually is a protective function. It's a protective response of the body. Body says, I don't want this exposure anymore. That's what its body is saying. That is why you get wheezing. What happens with wheezing? Narrows down the airways. Why does it narrow? It does not want any more of those antigens. Okay. Why do we start having stuffiness of the nose? The membrane swells up because it restricts the entry of the antigen. So it's a protective. But the protection is so strong, it causes damage to the tissues, host tissues. And that is what the allergic diseases are. And we end up treating symptoms with very potent medications like steroids, inhaled steroids, oral steroids, antihistamines, antileukotrienes. But what happened in the field of allergy was we spent a lot of time concentrating on medications without understanding the disease. So what we did not do was we did not collect epidemiological data. Okay. So how do you understand a disease? Say like you have one patient in your office and you see that patient. Will you understand the disease? You only understand the person but not the disease. So epidemiological data is essential to understand the disease. So that is why we have two major epidemiological studies called ISAC study, which is for children, and European Health Survey, which is for adults, that has helped us to understand the disease. Only lately, in the past 20 years, we are understanding allergic diseases. Now, before I go to specific things, I want to discuss what is the basic defect in allergy. Everybody orders serum IgE right away. They think it's IgE. It is not IgE. It is not IgE. IgE is a substance that is produced during the allergic inflammation. The basic defect is it is a combination of gene-environmental interaction. Genetically you are prone. But what is the genetic defect is the question. The genetic defect is in your epithelium. It's an epithelial cell disorder. Epithelium. So this is a diagrammatic representation of the epithelium. Epithelium means epithelium of the skin, epithelium of the mucous membrane. You know that skin is a very large, or it's the largest organ. Mucous membrane, you know, it is respiratory mucosa, gastrointestinal mucosa. If you just spread it around, it is as big as this room. That is the amount of surface area that is interacting with the environment. It is not just a small amount. If you spread the epithelium, spread the skin, it is as big as this room. Each one of us is having a huge area around us interacting with the epithelium. Okay. So that epithelium genetically in atopic persons and allergic person is weak. What is the weakness? The weakness is in the cement. That is, these cells are supposed to bound to each other. It should be tight. The epithelium should be very, very tight bound. And what keeps it tight is they are anchored to each other by, if you know some of the histology like adherent junctions, tight junctions, desmosomes. These are all the areas in the between the cells that keep them anchored. And these cells are also anchored to the basement membrane. So it's a very tight thing. In allergic persons or people who are prone to allergy, that tightness is not there. Okay. So if you want to imagine, if you look at your flooring, you see those tiles. Okay. It is a uniform flat surface of the flooring you're seeing. But what is keeping that flooring so flat and smooth is between the tiles you have a substance called grit. Okay. And that grit, if it is broken, water leaks into the floor and the tiles will raise. So the surface becomes uneven. Same thing here. In allergy, the tissue between the cells gets leaky and there's an entry of these environmental molecules. It could be allergen molecules, pathogen, bacteria, whatever, and that causes the inflammation. Okay. So it is a leaky mucous membrane, leaky skin that causes the entry of these noxious agents, and that causes the immunological reaction. Okay. Now, we call T cells, we say B cells, just to keep it very short. What is a T cell? What is a B cell? Both are lymphocytes. T cell is a cell that is a trained cell. So from the bone marrow, all the lymphocytes are channeled into a very important organ called thymus, which pediatricians are very familiar. In the thymus, so this happens in utero. At 6th week of gestation, your immune system is totally functional. It is able to produce immunoglobulins, okay, at 6 weeks of gestation. So these lymphocytes enter the thymus. In the thymus, it is exposed to self-antigen. If your lymphocytes recognize that self-antigen, it is destroyed right there. That is called apoptosis, cell death. You don't want your lymphocytes recognizing your own tissues. Okay? That's what causes, when you get older, the surveillance get looser, and then you get autoimmune diseases. You don't want that. So the lymphocytes that do not recognize your own self-antigen will come out of the thymus as graduates of, so they are actually educated by the thymus not to recognize the self-antigen, and those are called T lymphocytes, thymus educated lymphocytes. They comprise 70% of your lymphocytes. 30% is B cells. B cells is the antibody. It is a lymphocyte again, capable of producing immunoglobulins, and that is matures in the bone marrow. And the immunologists have this capacity or the way to give nomenclature which confuses everybody. They call it B cells because it is sort is coming from the bursa fabricius in the chicken. Bursa fabricius in the chicken is in the cloacal area, which is analogous to our bone marrow. Okay, that is where it is produced, and that is why that B came, B cell. That is one way of one of the explanations. So anyway, what I want you to know is T cells are thymus educated, B cells are maturing in the lymphocytes, in the lymph nodes, and that they produce immunoglobulins. So if you look at a normal allergic reaction, what do you mean by an allergic inflammation? This is another diagram. There are two phases. The first phase, initial exposure. Through that compromised epithelium, the allergen enters and picked up by this cell called antigen presenting cell. Antigen presenting cell is called by different names, dendritic cells, Kupffer cells, and this picks it up, and that is a very intelligent cell. And all these things are occurring in the lymphatics, and allergic inflammation occurs in the lymph nodes, not in your blood. Okay, so all in the lymphatic system is alongside the cardiovascular system. You have the lymphatic system. So there it is exposed to the T cell in the lymph nodes. If you take a cross section of the lymph node, you have T cell area, B cell area. That's where all the action takes place, and the T cells will tell the B cell to produce the IgE antibodies if it recognizes that particular antigen as foreign, or if it is not recognized it as foreign, it will say just IgG antibodies. That is how the IgG antibody is formed as more of a, like a registration. IgE antibody is produced so that it will not enter again, or it will fight the re-entry, and that's what happens with re-exposure. The IgE molecules will be either free in the blood as free IgE, that is what you measure when you do specific Ig or immunocap, or it will get hooked onto the mast cells or basophils, which is present in the skin or mucous membrane, so it's ready for protecting you, and that is what we measure when we do skin testing. That is when you expose the antigen to the mast cells which contain the IgE. So this will give you some idea what we are talking about. So there is two phases. One is called sensitization, that is when the mast cells are armed with IgE molecules, or the IgE molecules are specific or circulating, that is called sensitization. With re-exposure, you have allergic inflammation where there's a release of histamine, tryptase, leukotrienes, prostaglandins. That is when you get the symptoms. Now, I just showed you this because that is where all the action takes place in the lymph nodes. So there are this terminology here. We use the term atopy, we use the word sensitization, we use the word allergy. I just want to point out that atopy is a genetic term. If you are prone for allergy, he comes from an atopic family. His uncle has allergies, but the child doesn't have allergy. That means the child is coming from that family, he is genetically wired, no symptoms at all. That is called atopy. You do skin, say like you are 100 of you here, I skin test you, 50 of you might react to dust mite, 30 of you may not react at all, 20 of you have positive, you may have a family history of allergies but no symptoms. So out of the 50 who reacted, only 10 of you may have symptoms. So what it means is 50 of you have sensitized. That means you have specific IgE antibodies in your skin or in your blood. That means you are sensitized. 10 of you have symptoms, that is allergic. Only 10 people are allergic, 50 people are sensitized, but another 30 do not have any allergies or any family history, but the other 20 have family history but no symptom, they are atopic. So genetic state is atopy, immunological state is sensitization, clinical state is allergy. So just because you have a positive skin test doesn't mean you have allergy. So you can be sensitized, no symptoms at all. So 50 of you, out of 50, maybe 10 of you have, 5 of you have symptoms, 5 or 10, other 40 do not have any symptoms. So what the message is do not treat skin test, do not treat immunocap, treat the patient. So only when they have symptoms, that means they have allergy. Just because they have positive skin test, positive immunocap, do not treat them, just follow them. So you can be atopic but not allergic. That is, you can have a family history but not have any symptoms, or you can be sensitized or not allergic. That means you may have IgE present in your system, specific IgE, which is manifested by positive skin test or positive immunocap, and no symptoms at all. This happens in food allergy a lot, where the patient, the mom comes to you and say, you're treating my child. He's 8-year-old, has allergies, but I want you to check this child also. He's 4-year-old. And many times, unfortunately, what is done, no history is taken. Okay, let him go to the lab, we'll get some blood drawn for immunocap. So they get the blood drawn, but this will show many, many positive reactions. The test is correct, but the diagnosis is wrong. You cannot say he's allergic, he's only sensitized, no symptoms at all. So what is the difference between a sensitized child and a non-sensitized child? So there was a study done in Rhode Island where they followed sensitized students, like in a university, it's a captive population. They are there for several years. So they followed these patients for the next 25 years, and they found if you are sensitized, chances of you developing allergy is 10 times more compared to non-sensitized. So when you have sensitized patients, you need to follow them. Even though they don't have symptoms, they are at a higher risk of developing allergy. So let me go to food allergy. Now, food allergy is very similar to the drug allergy, where they use all sorts of terminology. People have certain symptoms when they take particular food, and they will say the word allergy to it. But if you take food allergy alone, which is supposed to be an immunological reaction, an abnormal immunological reaction, either IgE or non-IgE, the number of patients who get actually immunologically involved is very small. Okay. But adverse reactions like foods can bother you, can give you stomach ache, can give you headache, and can give you not feel good, and that is not allergy. So, or it could be a toxic reaction like food poisoning. or it could be a psychological reaction. You may not like a particular food, and when you take it, you don't feel good because there's a mind-body connection. When you take that food, you don't feel good. That is not allergy. So you need to have a proper history to diagnose food allergy. Now people ask, how do you diagnose food allergy? Diagnosis, there are 3 things that are necessary to diagnose food allergy. Those 3 things, first thing is history. Second thing is history. Third thing is history. It is not IgE, it is not skin test, it's not even a cap. So history is most important. So why is history so important? Because history plays a major role in the diagnosis, and there should be what we call as a temporal relationship. You take a particular food, within a certain period, you will have a reaction, you will have some symptoms. Okay. Generally, it's about 2 hours. This is for IgE mediated. I'm talking about IgE mediated. So that relationship is very important. Say like you take a particular patient, the skin test is positive, but does not have any temporal relationship. It probably is not at all a food allergy. He is sensitized but not having any allergy symptoms. So it is quite a tricky thing for you to get confused in food allergy, because on one hand, history is weak. On the other hand, the blood test is positive or skin test is positive. So you can only say that patient is sensitized but not yet allergic. So that is where the confusion comes. So many times physicians get confused because test is showing something, history is showing something, so they don't go along. So our job as allergy specialists is to put things together, history and lab together, and that is what correlation means. You have to put those 2 things together. They have to match. Which takes the upper hand? Is it the lab that takes the upper hand, or is it the history that takes the upper hand? We feel it is the history that takes the upper hand. It is not the lab. So the patient, whatever he is saying, takes the upper hand, not the lab. So if you take the different immunological reactions to food, it could be IgE mediated, which you are very familiar with. It could be anaphylaxis, oral allergy syndrome, immediate gastrointestinal allergy. Very few people get respiratory symptoms, or many people get skin issues, or it could be a mixed one like eosinophilic gastritis, eosinophilic esophagitis, or it could be a non-IgE mediated reactions like food protein induced enterocolitis, which is more of a protein intolerance, which we'll just touch upon lately. Now, how prevalent is food allergy? If you talk to your patients, are you allergic to particular food? 25 to 60% of people, depending upon which article you quote, will say I'm allergic to this food. But actual true food allergy is very, very small. But the perception is very high. So you need to have a proper history taking to figure out what who has got a true allergy, who has got just a perceived allergy. For example, for myself, what happened was when I got engaged to my wife, they invited me to their home. They gave me a type of a brinjal type of stuff, which I did not like. Actually, my sister-in-law had told her, he doesn't like that brinjal, don't give him that brinjal because he won't like it. Unfortunately, at that day when I went there, they had cooked the same thing, okay, and I ate there, and I asked for a second serving because it was so tasty. I did not recognize which food it was. And then after I ate all that, she quietly tells me, do you know what you ate? I said, I don't know, but tasted very good. I like it. And this is what you said you are allergic to. Your sister-in-law told me that you should not, I should not serve you that, but I have served you that. She gave me a food challenge before marriage. And I was, and it was a negative challenge. And since then I am liking that food and I eat it. So what it meant was I had a psychological barrier. And I thought it is allergy. And she disproved it before getting married itself. And now I am eating it. So what it is is you can have allergy due to we may think it's psychological. So I want you to think beyond IgE, beyond. So these are things that you will know only when you get a good history. Okay? And I also put their prevalence higher in certain people of atopic dermatitis. Say, for example, I told you prevalence is very, very low. It's only less than 1%, less than, could be 10%. But if you have eczema, the prevalence of food allergy in eczema children jumps up to 38 to 40%. So 38 to 40% of eczema patients have food allergy. Okay. If you take anaphylaxis, jumps up higher. Almost foods is a very common cause for anaphylaxis, almost 45 to 50%. Okay, drugs and foods compete with each other to cause anaphylaxis. So, and also the food allergies or allergies in general is more in cold climates away from the equator. Being near the equator, right here, like Sri Lanka, India, southern India, seems to have some protection. Okay. Whether it is due to vitamin D3 or what, so that is something that is sort of, we wonder about that. So, what are the types of foods that bother people? This is Western data. There it is milk and egg compete for number 1 position. And they cause the maximum amount of food allergy. Then comes peanut, which has got incredible publicity. More people know about peanuts, as many people know about peanuts as Kamala Harris. It's a household problem. Everybody say peanut allergy. India, nobody talks about peanut allergy. Every day we are eating peanut. In America, everybody is worried about peanut. How is it India and China consume so much of peanuts and does not have much peanut allergy? Why is that in USA they consume a lot less than us but have a significant amount of food, peanut allergy? One of the reasons is the way you eat peanuts. Here it is raw peanuts or boiled peanuts or fried peanuts, and they are not that antigenic. In USA, they eat what we call as dry roasted peanuts, where it is heated up, and when you heat it a particular temperature for a certain amount of time, the proteins on the outer surface, the amino acid configuration of the outer layer of the peanut undergoes some changes, and that makes it more allergic 90 times more. And that is one of the reasons why peanut allergy is so common there. And it is now coming here also because of globalization. People have a lot more money here, and they are packed in very attractive packets. And nowadays people don't go and buy these raw peanuts. They always go to these very fancy shops, put 500 rupees and buy these peanuts. When I was a kid, I had never seen a 100 rupee note. Okay. When we saw a 100 rupee note, we keep on looking at it. Okay, we never used to spend. So at that time, socioeconomically was a different life. Now it's different. People have access to a lot more funds and highly allergenic foods also. Now, I know I'm short on time, but what can I do? So this is the Indian data. Look at the Indian data. You look at here, Indian data. This is the data from Dr. Mahesh study. It's a Europe-Revolve study done. Around 40,000 subjects were analyzed, looked at, and finally only around 150 people had significant allergies only by history, very small percentage. And if you look at the type of history they have, the type of foods that caused problems were mostly sunflower oil, palm oil, eggplant, not milk, not egg, or not peanuts. Totally different. Brinjal, like I was sensitive to brinjal. And I know my daughter-in-law is allergic to brinjal, but they can eat egg or milk, no problem. Peanut, no problem. So, that is why I am saying, very important to get our data. our data is very different from Western data. Don't be carried away by Western data and say peanut is the most common allergen here. No, it is not. Milk and egg is the most common. Not. It is something else. So we need to find out. Okay? And this is just the beginning. And this data is confined to a particular area of Mysore, Bangalore, where 35,000 people were analyzed. So what we need is data from north, south, east, west, because India is like 25 countries together. When I say India, it includes Ceylon also. So we have so many ethnic populations, so many types of foods. So our data will be very different from the Western data. So one comment about the specific IgE, if you are doing a lot of specific IgE or immunocap, they call it is a trade name. It is a good test, there's no problem, but it's an expensive test, gives you a lot of false positives and not a good screening test. The best screening test for food allergy is a little bit history and a few skin tests. People will say, how many skin tests should I do on a pediatric patient? So we analyzed about 2,000 charts and found that there are only 10 foods that cause 80% of the reactions. So you do not need too many tests for detecting sensitization in children. About 5 inhalants, about 5 or 6 foods. So that will be around 10, 2 controls. 10 to 12 skin tests will help you to figure out how much of a sensitization the child have. You don't need 35, 40 tests. And what are the symptoms of food allergy? It is not gastrointestinal, it is skin. Okay? Then 80% of these patients with food allergy, the first symptom occurs in the skin. And one of the first things people talk about when they eat a particular food they are allergic to is, I feel hot or I feel itchy. Okay, is the first complaint they will say. Why are they saying that? Why are they saying they feel hot? It's because of histamine release. It is a sign of mast cell activity. Okay, and that causes vasodilatation and also produces itching, which is a neurogenic itching. Okay, and then you start also having urticarial rashes and other symptoms, which is due to other substances produced like leukotrienes, prostaglandins. But the first symptom is mostly dermal. Could be anaphylaxis. So as I told you, temporal relationship, and there are other combinations like exercise-induced food allergies and all that, which I cannot go through because of time issue. Now coming to skin test. Skin testing for foods, there are positive skin test and negative skin test. Which is more useful? So what is a positive skin test? Positive skin test is depending on the measurement. Any skin test which is 3 millimeters more than the controls, it is called positive. How good is it? What is the reliability, or what we call as a positive predictive value of a positive skin test? Is positive predictive value is a measurement of what is the likelihood of a challenge of a positive skin test. Say like you have a positive skin test, I give you that food, what is the chance that you will have a reaction? It's only 40%. There's a 40% chance of having the disease. That means the same thing as sensitivity. How sensitive is it? Sensitivity is a measure of a particular test in diseased patients. Do you have disease when you have a positive test? It's only 40%. 60% of patients do not have any food allergy with a positive skin test. That is the very important. So when you have a positive skin test, patient says, oh sir, it is positive. Is it significant? Just looking at the test, I cannot tell you. I have to go back to history. Does this food bother you? And still I am not getting it. I am confused. Positive skin test confuses everybody, including immunocap. Then what do? I have to do oral challenge. Unless there is a very strong history, this patient took this food, in 15 minutes had broken out with hives and tightness in the throat. I don't even need a test. That's a straightforward, strong history. But not everybody has that strong history. Okay. So you end up with oral challenge. Now, I do a negative skin test. Test is negative. What is the negative predictive value? What is the value of a negative test? It is 95%. That is, the skin test is negative in patients who do not have food allergy in 95% of the cases. That means a negative skin test is much more easier to interpret than a positive skin test. Okay. So I'm presuming here that the antigens are all of good standard. A lot of times food antigens are not commercial food antigens are not that great. What you eat and what you test are different. So what is the best testing material to do foods? Is the actual food itself. You don't have to buy any food testing commercial extracts. Patient says, I am sensitized to milk, it bothers me. Bring the milk, I will test you with milk. It's more scientific, it's crude, but it makes more meaningful, and that is the best way to do skin test, because commercially available antigens are not only expensive but sometimes very confusing. I had a mother-in-law, daughter-in-law case. I remember that. Mother-in-law, my daughter-in-law, every time she makes the dosa, mixes this dosa mix, breaks out. Mother-in-law obviously doesn't believe her. No, you are faking. You don't want to make a dosa for me. That's why you are complaining all that. Both of them come to my office. Sir, this is one, she says she's breaks out. I don't think so. I think she's faking. She wants to be lazy, does not want to make my dosa. I said, don't worry, I don't have a test for very good dosa, but how do you make the dosa? I do this rice flour, and what is the other flour? Urad dal. I say, okay, bring urad dal and rice to me, bring that stuff to me. They will bring it very gladly. I make up my own dilution, I filter it and make up a solution, urad dal and rice and saline and histamine. I test the daughter-in-law, I test the mother-in-law also as a contrast, I test my nurse, and the daughter-in-law breaks out with a big reaction to urad dal. Nobody else does. Test is positive for urad dal. She is not faking. Okay, she has a strong history. She also has a positive skin test. A strong history and a positive skin test, I am convinced that she is definitely sensitized. Okay? So that is the issue that you need to know with food allergy. You need to get the real stuff. Another case I had. Boyfriend brings this girlfriend, takes her out for dinner, and he's happily giving her the salmon fish, full dish. Within 10 minutes, she eats the salmon. She starts feeling, I feel hot, I feel itchy. And this guy had that common sense to immediately take her to the emergency room. They gave her epinephrine, antihistamines, they get better, and they end up in our office for testing. I said, okay, when you have anaphylaxis, we generally don't test you right away. We wait for a couple of weeks, and then until then you carry the EpiPen, come back. I do skin test, negative for salmon. What do? History is strong, skin test negative. I can't go and say, go and eat some more salmon, let me see what happens. Let me see if you are going to die in front of me or anaphylaxis. I can't say that. Then I say, bring the salmon, I will test you. She brings this whole big plate of salmon, and I wanted only small drop. I take a small piece of the tissue, test her with that, and then I put a histamine saline. I also test the boyfriend, I test the nurse as controls. This lady develops a big reaction to salmon. And that rest of the salmon is eaten by my nurses. They are very happy. They enjoy it. She is smart. She brought us free salmon. And so what the diagnosis here was, she has got true sensitivity. History is strong. Skin test negative. Then I pricked the salmon, and then I pricked her. That is called prick on prick test. And prick on prick test is used extensively in food allergy. So the point here is, do not just stop with commercial extract. Go to the real food. Get the real food and test. That is more useful for you, not commercial stuff. So this is what it is, and I will go really fast now because Dr. Govani is looking up and down, and this is called cross reactivity, and this is called pollen allergies food syndrome, where you can be sensitized to a lot of grass and weeds and this and that, but there's a cross reactivity between the pollens and the fruits and vegetables you're taking, okay, and that can cause problems. So it is not uncommon for people to have, everybody has heard of Parthenium allergy. Parthenium, everybody is familiar here. Parthenium is also called Congress grass. There is no BJP grass, there is a Congress grass. So Congress grass was actually brought in from the US as a contaminant of wheat when India was importing wheat. So it cross reacts with melons, watermelon, cantaloupe and all that. So people who are highly allergic to Parthenium, when they ingest watermelon, they start having itching and swelling because they cross react. Okay, that is something you need to know. So what happens to food allergy is a very, very important question. My child almost died of food allergy to foods. I almost so worried. What will happen, doctor? What is the natural course of food allergies? That is the question parent was. What will happen 5 years from now? Good news, food allergy gets better on its own. Not with all, especially with milk and eggs and wheat, they get better. They get better. 80% of food allergies get better by the age of 6 years. But now we are saying because of whatever changes are happening, that 5 years is getting extended to 10 years, 12 years like that. But by teenagers, 80-85% get better on their own. No treatment. On their own. Egg allergy, same thing, get better. What happens to peanut butter? Peanut allergy. They don't get better. Only 20% get better, 80% persist. Tree nut, same thing persists. Fish, same thing persists. So what happened with milk and egg? They got spontaneously better. How is it? How is it allergy got better on its own? I wish I knew the answer. If I knew the answer, I will solve the problem. So we are still researching that. Very interesting. No other allergy just gets better on its own. It's such severe ones. Okay, I will go faster. Changing scenario. Scenario is changing because it is getting increasing, it is getting more severe, lasting longer. But one of the things that is changing is, we are saying now, how is food allergy being caused? I get a vegetarian family to my office, 100% vegetarian. And the skin, when I do the test, child is reacting to shrimp, fish, chicken also. Mother is going ballistic. Ayoyo, we stay away from egg also. How is it you are doing? You must be a horrible doctor. You are telling my child is allergic to chicken. Is something wrong with you? Nothing is wrong with me. Nothing is wrong with the test. What has happened is the sensitization of that child has not occurred through the mouth. It has occurred through the skin. So they have found skin is antigenic, gut is tolerogenic. Skin is allergenic, gut is tolerogenic. So what has, I told you already, the epithelium is weak in children, atopic children, allergic children. So they go to food court or any restaurant, and the server will come and cleans the table. You think it is clean. It does look clean. But they have analyzed, they have taken these tables and scraped and looked at the measurement of different food particles on the so-called clean tables and found multiple antigens on that table. It is chicken, it could be shrimp, it could be pork, it could be this milk. So the child is sitting on the table and putting all the hands and tapping and happily playing. What is happening is those food antigens are entering through the skin and getting sensitized. Okay? and sensitization has occurred to the skin test is positive. So important thing is sensitization has occurred to the skin, and food is consumed and nothing is happening to the mouth. So that is how the LEAP study came into picture. They found that children who ate peanuts, where peanut was introduced very early, were not allergic at all later on, but people whom we avoided the peanut were more allergenic, because what happened was they were being sensitized to the skin. So the point is here, very important thing that came out of the whole thing was, if you eat the same food early enough, actually you can cut down on the sensitization through the skin. So a gut will induce tolerance even to the antigenicity of the antigen through the skin. So that is why they introduce this allergenic food early, so that the sensitization will become less and less to the same antigen. So it's confusing, and that is what the basis behind the this thing about the LEAP study. So I will stop here, because one last slide. So what we used to say and what we say now. We used to say avoid allergenic foods. We now say introduce allergenic foods. We used to say avoid cats and dogs. We say have dogs, because what has been shown is having this microbial exposure early enough during pregnancy, in the first 18 months of life, actually drives the immune system towards Th1 pathway. So we did that study in India, in our own hometown in Mysore, and 40 miles away in a village, and found that children who were in the village, who were exposed to all the so-called dirt, cow dung and all that, and they put cow dung lotion on the flooring and everything, and people, and these villagers even have a bedroom for the cattle inside there, they sleep with them. So the close contact with animals and also so-called dirt have got significant microbial exposure. This microbial exposure has a protective function even it starts during pregnancy. So you can't tell the city people to go use cow dung in their house. They think you are crazy. So the one thing that they found was having a dog is equal to almost having a same microbial exposure as a cow dung. So we tell our patients, get a dog and have the dog indoors. Let the pregnant woman sleep with the dog instead of I'm just kidding. Have that close have this dog in the house. Have children play with it. So this microbial exposure seems to protect the child from not going into Th2 pathway. And we used to say food allergy is untreatable. Now we say introduce these foods early enough. We used to say no immunotherapy. Now we are saying oral immunotherapy. So all these things have changed. Let me stop here telling you the most important thing you can tell your patient, even before the child is born: take care of your skin. The problem is in the skin. And the child is born, make sure there is enough emollients. You see, now we go back 50, 60 years ago. You see grandmas they bring their grandchildren, put oil all over the body and give the bath, and the child doesn't like it, but the grandma likes it. The mother is worried, yo, what's happening, the grandma doing. So all that type of treatment, putting oil and all that, probably had a good effect by sealing the skin, not allowing all these different antigens, and having a homemade food is much better. So they have shown one very important thing I want to tell you, Dr. Guwani, before I stop, is child is growing, getting hungry. Now the bottle is introduced. Formulas are introduced because they make so much of advertisement. The best complementary food that you can give for a hungry child of 4 months or 6 months is what we call homemade food. Whatever you are eating, you put it in the blender, make it easy to swallow and digest, give that food. They have found that having diversified food like what you are eating gives you the best microbiota And the evidence of giving homemade food to prevent food allergy is A+. A+. They have looked at the meta-analysis. They found 5 out of 5. It seems to protect food allergy. Okay, 5 out of 5. So the message is, if you want to give more food, give the food you are eating. Don't go and buy it from the commercial, which is not the best thing to do. So let me stop here. Thank you for giving me the chance to expose this. Thank you. I'm sorry I took more time, but this topic is a very wide topic, so I can't help it.
Thank you, sir, for that very interesting talk. Thank you for sharing your time and knowledge with us. And we are moving on to the last presentation, practical approach to drug desensitization. It will be done by Dr. Ajit Amarasinghe, consultant pediatrician who has a special interest in allergy. So it's a very interesting concept, and I hope you can finish as soon as possible.
Thank you very much for the College of Pediatricians for giving me this opportunity to present this. Thank you very much, Professor Vedanthan. I think I was your first student from Sri Lanka in 2012, and then it was UNE. So this presentation is not on the aspects, the theoretical aspects and the presentations of food and drug allergy, but a method of managing, which is called desensitization, which is also called as immunotherapy, and how it is being done in Sri Lanka. I think Dhanushka first explained the basis of food and drug allergy, and also Professor Vedanthan explained the clinical presentations of food and drug allergy. So I will be presenting how you could manage when you get a child with food or drug allergy. So this is a brief presentation of 103 patients whom I desensitized with who had drug and food allergy at my clinic. So I will first explain the sequence of events that would happen. So a person would present to you with drug or food allergy. So what is most important is to take a good history and confirm that the patient has a definite type 1 hypersensitive reaction to a particular drug or food. This is very important. So how you could diagnose a type 1 hypersensitive reaction and differentiate it from other types of allergy, I think Dhanushka and Professor Vedanthan explained. And also subsequent to that, you can do a skin prick testing, or for food allergies there are specific IG tests. But I would like to say, whatever the test results would be, what is most important is the history. So even if you get a negative test in IG, specific IG, or in the skin prick testing, still the patient can have a reaction. If there is a history of a reaction to a food or drug, the patient can have subsequent reaction also, even if the tests are normal. The other aspect is that even if you do the test, skin prick testing or specific IG test, if you ask the patient to take the food or drug, the patient would be reluctant to do that because they have experienced it. So therefore, what I depend mostly is the history, not the tests, either specific IG or skin prick testing. So skin prick testing, I have test material, and when it comes to drug allergy, I take the drug itself and do the skin prick testing. So in the history, what is more important is to determine the severity of reaction. Right. Now, if the severity of reaction is mild, This particular type of desensitization could be done at home over 6 days. If it is severe, I always admit the patient and do it over 24 hours with precautions for severe reaction. And if the history reveals that it was anaphylaxis, you should not do the desensitization process. So after the desensitization procedure, you must tell the patient that the patient has to take the drug or food at least once a month to keep his desensitization status. That is very important. Now supposing a patient is having amoxicillin allergy, you do desensitization, and it is very important at least once a month the patient takes at least 250 milligrams of amoxicillin. So actually I don't have time to explain the scientific basis on which these are made. These are all based on research material. So up to now, we have done desensitization in 21 paracetamol allergic patients, Comex to have 4, mefenamic acid 8. Now of these 8, 1 patient reversed back because the patient moved to Australia and he forgot to take the mefenamic acid once a month. Aspirin 5, amoxicillin 11, theophylline 1, ibuprofen 3, chlorpheniramine 1. It's very interesting that there was a patient who was allergic to chlorpheniramine, cefalexin and metronidazole. So these are the food items I have done desensitization. Beef 1, tomato 3, milk 12, seafood 7, ginger 1, coconut milk 4, egg, alcohol. So anybody who is allergic to alcohol, you can come to me, I can desensitize. Fish and wheat. So now we come to the procedure. It's very simple. This was actually like a home made type of a procedure. After several experiments, I found the easiest form of desensitization and the procedure of making the desensitized material. Now supposing you have a patient who is allergic to milk. So you do the desensitization from milk itself. So if it is allergic to amoxicillin, you take the amoxicillin syrup. So take the drug or food in the liquid form. You need 1 10 cc syringe and 5 cc syringe, 6 cups to make the dilution and 18 small bottles to make the preparation. And all allergy clinics need to have an emergency kit. Very important. So the aim is to make a dilution which contains 10 to the power minus 6 of the final desired dose. Now supposing you want to give the child a 10 ml of milk. So you make a dilution of 10 to the power minus 6 and start desensitization from that amount. So how you begin this is by adding 10 ml of solution to the first bottle. Now in this case, I added 10 ml of milk to the first bottle. Then you take 10 ml of milk from the previous bottle and put it in the second bottle and add 9 ml of water into the second bottle. So you go on doing this in 6 bottles. It is diluted by 10 to the power minus 6. I think you can understand that. So the last bottle will have 10 to the power minus 6. Then, so you can see the difference in thickness. The last bottle is almost like plain water, but it has milk 10 to the power minus 6. Then you take the last bottle and you have 18 label bottles. Start from the bottle 1. You take 1 ml from the 6th cup. Then the second bottle would have 2.5 ml and third bottle would have 5 ml from the 6th cup. Then you come to the 5th bottle and take 1 ml of out of. You can see that you are almost doubling the dose in these bottles. So at the end you will have 18 bottles, where each subsequent bottle would have double the amount than the previous bottle. So this is the difference between the first bottle and the 18th bottle. So then you ask the patient to take, beginning from the first bottle to the 18th bottle. So you will be taking starting from the 10 to the -6, doubling the dose, coming up to the level of 10 ml of the desired dose. So you can do it at home if it was a mild reaction to the allergen that you are desensitizing. But you can do it, I always do it in the hospital if it is a severe reaction. So after taking the 18th bottle, what you do is take 10 ml of drug or food each day and go on doubling it. Usually what happens is that when you take the third or sixth bottle, that is the time that the patient would observe a kind of a mild reaction, and it usually disappears. I think Professor Vedanthan would and also Goni would understand that is the time that the T1, T2 switch happens, I feel. And this is explained in immunotherapy research papers about a T2 to T1, T1 to T2 switch, so which is very important to happen. And I never had to abandon the procedure due to reaction. There were two failures in this series. One was the patient I told you whom I desensitized for mefenamic acid, and at the end the patient could take 500 milligrams of mefenamic acid without a problem. And he went on taking mefenamic acid once a month, and he migrated to Australia. He forgot to take it for 3 months, and then he suddenly took mefenamic acid. Again he got the reaction. So it is very important that once you desensitize, you keep on giving the allergen to maintain that status of desensitization. Now in a case of food item, it is not very difficult, because if you desensitize for milk, the child or the adult would go on taking milk. But whereas in drugs, it's very difficult, because the patient has to remember and take the drug once a month. So I have been doing this since 2019. I have a series of 102 patients now. None of them had any kind of a reaction, no anaphylaxis. Few of them I had to admit to hospital and do what is called rush immunotherapy, where I had to give these 18 bottles over a period of 24 hours. And the rest of the patient who has had a mild urticaria or a mild angioedema, I asked the patient to take the first dose at my clinic and take the subsequent doses at home, and none of them had reactions. But what is more important is, I think, patient selection. Number one is, by the history, you have to make sure that it is definitely type 1 hypersensitivity reaction, nothing else. Number two is that you must make sure that you make the dilutions correct. And number three is that you must make sure that you do not do it in patients who had severe allergy. The severe allergy, especially anaphylaxis, I mean, it's also recommended that immunotherapy should not be done. I think this is a brief presentation. I don't have to go into details of the theory behind this procedure. There are many researchers done, many types of desensitization methods. And this is the most feasible thing I devised. I think I did the postgraduate diploma 12 years back. I was trying various methods, and I think about 4 years back only I switched to this method. Very easy, very patient friendly, and very clinician friendly, as well as if you do it in the hospital, it's very easy for nurses to understand how this is done. Thank you very much.
Thank you very much, sir, for sharing your experience. So, are there any questions, burning questions? We can have 2 minutes, or else you are busy and want to leave. Any burning questions for any of the speakers? We can give 2 minutes. Anything you want to clarify? So in the absence of any questions, we will conclude this session. Thank you very much for the speakers and sharing your knowledge and experience. Thank you.